Good morning. Thanks, Nick. I'm really pleased to be invited to come and attend. This is my first coming along to one of these GIST Cancer UK meetings. My name's Alex Lee. I'm, as introduced, a medical oncologist working primarily at the Christie, but I'm part of the wider Greater Manchester and Oswestry Sarcoma service. So spend a fair proportion of my week looking after a group of patients in our area, treating for various parts of their journey with GIST. Today, mine and Professor Stark's talks are maybe a little bit back to front, primarily because I have to dash off and get back for an afternoon clinic. So I think Dan's going to be setting a bit more of a scene around GIST generally, whereas I'm going to talk about some of the drugs that we have nowadays to treat. I'm aware that there's a mixture of people in the room, patients, carers at different stages of their journey, people perhaps only just recently diagnosed, others who are patient experts who have been experts about GIST long before I even heard about this sort of cancer. So my talk today is perhaps more aimed at people earlier in their journey, trying to provide a bit of a background about what these drugs are, how they work, why they cause side effects, what those side effects are, and how they might be managed. So apologies if I'm telling some people in the room lots that they already know, but I hope it will be helpful for, at the very least, some of you. I do not know which button to press. Is it this one? Down one. Okay, it's my disclosures. Okay, so as I've talked about, we're going to talk about what these drugs are, what some of the side effects are, and some tips for management. Just to highlight, what I'm going to talk about today, I hope will be useful, but please don't act independently on anything that I say today. Please always discuss with your care team if you're having problems with side effects. Okay, so tyrosine kinase inhibitors, a very potentially quite sciencey sounding term. What are these drugs? What do oncologists mean when we talk about these? So first of all, what are tyrosine kinase? What are these things that are being inhibited? So tyrosine kinase are effectively proteins, enzymes, which are found in all the cells in our body, and they play important roles in transmitting signals within the cells that control the behaviors of the cells. So I've drawn some animations here, cartoons. So if we talk about KIT, which is a tyrosine kinase, which some of you will be familiar about the importance of this in GIST. So KIT is a receptor tyrosine kinase, so usually is found, if this is the cell here, this is the nucleus which contains the DNA. These sit on the cell surface and interact with what are called ligands, in this case stem cell factor in the case of KIT, which are soluble molecules released by other cells, other parts of the body, which are the way of transmitting messages between different cells, sometimes from different parts of the body. So here the ligand interacts with the cell surface tyrosine receptor. In most cases, they form what are called dimers, so they pair with another molecule of the same sort, which then activates the enzyme, which brings in other proteins from within the cell, phosphorylates them, so basically performs a chemical change, sticks a phosphate group onto these other proteins, which then in effect triggers a chain reaction where other proteins are recruited. There's a cascade of signals, the one above activating the one after, which eventually results in the nucleus, different genes being activated and making the cell behave in different ways, which in many cases might be telling the cell to grow, to divide, to resist dying, or to undergo shut down if something's gone wrong with that cell. So in normality, this is a highly regulated system which is under control by neighboring cells and is highly evolved. Now in cancers, what can happen is that these signaling proteins get mutated and are stuck on the on position. So here I've put a little bulge there to replicate that. And what that means is that this will always be turned on and is no longer dependent upon these extracellular signals turning them on, not necessarily dependent on the dimerization pairing with other molecules of the same sort. And this means that the downstream signal is always activated. Those growth, survival, cell division signals are left turned on. And this can lead to cancerous behavior. So, for example, in GIST, where in many cases there will be an activating mutation in KIT protein. There's this on signal that's left that's just telling the cell to grow, to divide, to resist being told to kill itself, which leads to the cells dividing and the tumours ultimately growing and behaving dangerously. So what are tyrosine kinase inhibitors? They are molecules that have been specifically designed to turn off these switches that are stuck on the on position. So if we again look at this animation, kind of capitulating what I've just shown you there, and then in the mutated case, that signal's always on without the signal. Then what these tyrosine kinases are designed to fit very snugly against the on switch, turn it off, and therefore blocking that downstream signal from happening. What can happen is that there can be further mutations within these proteins, which means that the tyrosine kinase inhibitor no longer fits, and the protein becomes resistant and can still activate the downstream signal, which sadly is something that we do see in GIST ultimately, even when these drugs work very well. So hopefully that's given you a sense of what these drugs do at a kind of a biological, a chemical level. But we have lots of different ones, and what I've just illustrated there about KIT, there's lots of different tyrosine kinase proteins which work in slightly different ways, have different effects within the cells. And because of that, there are different molecules that inhibit things in different ways. Now, these figures here are kind of maps of all the different tyrosine kinases there, and these are where there are red blobs are the areas where the drugs inhibit particular drugs, inhibit particular proteins. So imatinib, which is a drug many of you will be familiar with, you see here, so the size of the red blobs are the potency of inhibiting that particular protein. So as you might see, it's relatively limited and quite concentrated around here, where the big dot there is, well, one of those big dots is KIT. If we look at sunitinib, which is another of these tyrosine kinase inhibitors used in the treatment of GIST, again, some of you will be familiar with this. It's a much busier diagram. What this indicates is that sunitinib is much more promiscuous in its targets, whereas imatinib is more specific. Sunitinib hits lots of different targets. And then regorafenib, a slightly different pot there, but showing a similar thing. Again, slightly more busy diagram representing that regorafenib is less specific. It hits more different targets. This table is basically showing the same thing in different formats, with all the different tyrosine kinase targets down the left, and then the ones which are particularly inhibited by imatinib, sunitinib, then regorafenib. And as you might get a sense here, some of these targets overlap, but not all of them do. Highlighting importantly, all of these drugs do inhibit KIT and PGF receptor, which are important in driving GIST behaviour. I'll draw your attention down here, VEGFR. This is a tyrosine kinase that's very important in driving the cancer's ability to grow new blood supply, which they depend upon to survive. And these drugs inhibit VEGFR, whereas imatinib doesn't really, which is an important factor as we come to talk about side effects. So coming on to imatinib. So as indicated there, imatinib is a potent inhibitor of KIT and PGFR alpha, which between these two genes accounts for the driver of GIST cancers and probably up to about 90% of GIST overall. Over 2 decades of clinical trials, approaching 3 decades, imatinib has been shown to be a highly effective treatment for GIST when there is a presence of a KIT or PDGFR alpha mutation. When there is advanced disease, or when this KIT, which was in the body, which we can measure, there is a high rate of imatinib bringing about shrinkage of the tumour areas, and that and typically that will last for a number of years before ultimately resistance is seen. And it's also been established that after surgery, where there isn't any evidence of GIST remaining in the body that can be detected, that giving a course of now standard 3 years of imatinib makes a significant difference in the very least delaying, if not preventing, the recurrence of GIST. Initially, imatinib was synonymous with Gleevec, which was the brand name of the company which originally developed imatinib. Now that the patent has expired for the use of imatinib, it opens up the market for other companies to make their own version of imatinib, which are considerably cheaper than Gleevec and are now, over the past couple of years, have been adopted in NHS care. So the imatinib that some of you are taking may not be the same brand as the imatinib as someone else. And I think an important message which I'm keen to emphasise as I come and talk about side effects, which could give the impression that these drugs are bad news, is that for the most part, the experience of many patients with imatinib is that it's a well-tolerated drug which often has a very limited negative impact upon day-to-day life, and I think it's important to keep that in focus as I come to talk about side effects. So what are the side effects that are commonly encountered on imatinib? So it can affect your gut. So nausea, vomiting, diarrhea, giving you a funny taste, change of sense of taste in your mouth, causing heartburn, are among the more commonly encountered side effects. Fatigue is probably the number one reported side effect, making you feel more tired. Sometimes that can be associated with anemia, developing a red, potentially itchy rash, often quite diffuse across the body, is among commonly encountered side effects. It can cause uncomfortable or watery eyes. It can cause swelling around the eyes or sometimes around the ankles. And people can sometimes experience painful muscle cramps, particularly at night time. One would be unlucky to get all of these, although I think it's probably a typical experience that some people encounter some of these to some degree, particularly as they start treatment. And it has been observed that even if people do struggle with these side effects as they start imatinib, that often they will settle down. There does appear to be a tolerance that emerges after the initial months as well. So even if one is unlucky enough to have a tough time with this, it's not necessarily going to be the case that you have to put up with these for the full duration of your time on imatinib, and that's before one gets to the measures that might be employed to help. Come in. Oh, sorry. Importantly, it's worth highlighting as people start treatment for cancer, people have different conceptions of what being a patient on cancer treatment is. It is very rare to experience noticeable hair loss on imatinib. And similarly, the sorts of risks of infection which are associated with more conventional chemotherapies are not seen with imatinib. There is perhaps a slight increased risk of infection. There is sometimes some impact upon levels of white blood counts, but usually that's to a fairly insignificant manner, and for the most part people on imatinib are not significantly more prone to infection than the next person on the streets. I'm going to come and talk a little bit about the trial data that tells us about how often these side effects are seen, how severe they might be. To do that, to talk a little bit about how side effects are graded within clinical trials, which I'll come to refer to, which these are the criteria for what's called the common terminology for adverse events, or the CTCAE grading. So going from 1 to 5, though, there is also effectively a 0, which means no side effects or adverse event. 1 typically refers to those which are mild, which are not having a particular impact upon day-to-day life, which may just be picked up through blood tests but not actually noticeable to patients. Grade 2 is moderate, so symptoms are present, noticeable, but having a limited impact upon day-to-day life. There may be a need to give other treatments to help support those side effects. Grade 3 is generally severe, which may be starting to have an impact upon day-to-day life, the sort of thing which occasionally might land people in hospital to manage the side effects and might demand a change to the treatment, either interrupting the treatment, reducing the dose, sometimes even discontinuing. Grade 4 is life-threatening, grade 5 is fatal. Very thankfully, these are very rare to see with imatinib or indeed any of the drugs I'm going to talk about today. Mild and moderate certainly can be seen, severe occasionally. I'll come on to talk a bit more about that. So this is some data taken from the report of a trial, so the Scandinavian GIST investigation group, their 18th trial, which was comparing whether or not 3 years of imatinib was better than 1 year in patients who had had surgery to completely remove a localized GIST. So this is looking at the nearly 200 patients who received the 3 years of GIST, so there may be people in the room who are some way through this treatment journey. And then a list of the sorts of side effects. So at the top here are the number of patients who had any side effect at all, and as you can see here, 100% of people reported some kind of adverse event that may have been a side effect, and actually a third had something that was classed as severe or worse. Looking down the list here, so as I've already touched on with the emojis, anemia, swelling around the eyes, low blood counts are among the more commonly encountered, with tiredness, tummy upset, muscle cramps, and fluid retention. Looking at all of these, rare to get severe of these, and actually in this trial and other trials, the majority of the more severe side effects were the sorts of things where picked up on blood tests but not necessarily noticed by the patient. So looking at that, you get the sense that yes, people do get side effects with imatinib, sometimes severe. Yeah. It's worth looking at other trials to get a sense, well, how much of this can be accounted for by imatinib. So this is some data taken from a different trial, which was performed earlier, which was the one which established the benefit of imatinib as being a useful thing after surgery. So in this trial, patients either received a year of imatinib or placebo, and that allows us to have a look at the how many of these adverse events might be expected even if people weren't taking imatinib. And so on this slide, this is the effects of the imatinib matching what I've just shown you from the other trials. So some side effects in almost all patients, only 1% of patients have reported no side effects, with about a third of patients having severe things, even potentially patients passing away.
Can you just explain again for some people who might not know what placebo is?
Oh, of course, yes. So placebo is an interesting old notion. So this comes down to the fundamentals of clinical trials. How do we establish that treatment is useful? So in this instance, we have a group of patients who have just had surgery. We know that in some cases they're destined to remain free of any recurrence of GIST with no further treatment. We know that some patients are destined to experience recurrence. And so we're asking the question, if we give a year of imatinib, does that make a difference? So you could say, well, let's give everyone imatinib and see what happens, and we can compare that to what's happened in the past, and that provides some level of evidence. But then that gets you into questions of, well, maybe this group of patients, there was something different, maybe different people did their surgery in different hospitals. So how do we know that the imatinib is accounting for any difference compared to historical people? And so therein comes the notion of a control arm to a trial. So within this group of patients, we'll randomly allocate some to receive imatinib and some just surgery alone, which again is a fair design, but therein comes the placebo effect. We know that just through a doctor giving you a pill and saying this is going to help, that can manifest some benefit. It can make people feel better, it can make people more positive, it can potentially even make an impact upon whether or not cancer comes back, as far-fetched as that might seem. Conversely, if a doctor gives you a pill and says, well, this is going to cause you a side effect, this is going to cause you to feel nauseous, this is going to cause you to feel develop a rash, that suggestion has a potency to manifest those side effects. Again, as far-fetched as that might seem, but this has been demonstrated time and time again that this placebo effect can be very potent. And so if you're trying to establish whether or not the drug is making the difference, you want to control for that placebo effect. You want to know that it's the drug that's doing it, not just the fact that a doctor is giving you a pill with the suggestion it might be helpful. So this is so placebo in this instance is basically a dummy pill which outwardly would look no difference to imatinib, but doesn't contain the active drug. And so if you're experiencing potential side effects on the placebo, the suggestion is it's not due to imatinib. It might be because it's related to the underlying condition. It might be because people feel nauseous from time to time. If people on clinical trials may die from other reasons as well, and that's when you come to grade 5 toxicity, you'd have to account that if you do enough trials for long enough, people will pass away from unrelated reasons. And so again, it's an important way that we establish the effect of drugs, but also the potential side effects of drugs. Come in, please. So coming back to this figure, this is the data from the 300 odd patients who definitely received imatinib, tracking to the data from other trials. But then if we show that side by side with this potential side effects reported by patients who received placebo, you'll see that it's actually quite similar. And that actually, in terms of mild, you've got more patients who reported no side effects, as you'd expect. More patients reporting more milder side effects. With the expected excess in terms of more severe side effects, you are seeing a difference, the more happening with imatinib, but still it's not zero in the placebo arm. And if we look at the sorts of side effects, so all of these overrepresented in placebo. So actually more people reported mild or moderate fatigue, skin reactions, nausea and diarrhea who received placebo, suggesting that people get these symptoms regardless of whether or not you're on imatinib. These symptoms were certainly higher in terms of more severe ones, so low blood counts, liver blood tests. Again, these are more kind of objective measurements which patients wouldn't necessarily know about. Fluid retention definitely is seen more often with imatinib. So again, in this trial at least, some adverse events were more common with placebo. So, which I think is an important thing to take in mind is that and starting in imatinib, whilst the timing might be compelling, one has to bear in mind that it's not always due to the drug. There may be other explanations. This is some data from a trial that compared the current standard dose of 400 milligrams of imatinib versus a double dose, which we, in certain circumstances, depending upon the particular mutation, it's currently a standard to use a higher dose. In short, what this figure shows is that if you have a double dose, you're more likely to get side effects, more likely to get severe side effects across the board of anemia, tiredness, rashes and tummy upset, which demonstrates that many of these side effects are dependent upon the dose of imatinib. If you give more of it, on the whole, you expect to see more side effects. If you give a lower dose, you expect to see lower side effects, which is a useful thing to know as we come to try and figure out how best to support people when they do experience side effects of these drugs. Moving on briefly to sunitinib and then regorafenib afterwards. Sunitinib is the standard second drug treatment for use when imatinib no longer works for GIST that has recurred or is metastatic. As I referenced earlier, as opposed to imatinib, which is relatively specific in its inhibition of KIT and fewer molecular targets, sunitinib is more promiscuous and, importantly, whilst also inhibiting KIT, inhibits cancer blood supply generation. There's established trial benefit after patients have received imatinib. The rates of tumour shrinkage, or significant tumour shrinkage, are relatively limited, perhaps no more than 10%, but certainly in terms of keeping disease stable, on the whole, between 6 to 9 months on average. The standard dose is open to some debate. At first, it was used on a 50 milligram dose where patients would take it 4 weeks on, 2 weeks off. Increasingly, we use 37.5 milligrams continuously without a break. There's some data, not completely reliable, but some data to suggest that the continuous dosing perhaps works a bit better. And I'll show you some data which suggests while side effects are perhaps more commonly seen, it does seem that people are able to take the drug longer, and potentially therein may lie the benefit at the lower dose. The sorts of side effects that can be seen with sunitinib broadly overlap, which I've already shown you with imatinib, with some important additions: high blood pressure, a reaction in what's called the hand-foot reaction, which can be characterized by redness, soreness, sometimes even blistering in the hands and the feet, and can impact upon wound healing. So it's very important to be wary of sunitinib if people are having operations, dental work, things of that nature. But again, as I'll come to show, sunitinib perhaps on the whole can be a bit tougher with side effects than imatinib, but we still expect for a significant majority of patients to be able to take this drug with manageable side effects and, again, to have a limited negative impact upon day-to-day life. Oh, here we go. So this is quite a busy slide, which is just showing this is from a number of different trials, which we have to be wary of the comparison. But in blue, the 50 milligram 4 weeks on, 2 weeks off dose. In orange, the lower dose continuously and placebo data. Comparing the blue and the orange charts to the grey charts, you can see there is a significant difference across most of these side effects compared to placebo, and perhaps a slightly higher rate of more serious side effects, particularly as I say, with the lower dose taken continuously, but with trial data again that suggests, despite that, people do seem to be able to put up with the lower dose for longer than the higher dose. Which, where are my points all? I'll carry on. So the takeaway from this is that sunitinib perhaps is harsher with the side effect profile, which, you know, if you line up the sorts of side effects of imatinib to sunitinib, it does overlap. There are some additional things to watch out for, particularly blood pressure management. There's a slide around regorafenib, which is the standard third treatment that's used once imatinib and then sunitinib after it have the effect has worn off. Again, there's a trial data that's established that benefit. Regorafenib is a drug that's quite similar to sunitinib in its side effect profile. It is standardly taken on a 3 weeks on, 1 week off basis, primarily to allow a bit of recovery from side effects for a week, a month. Again, there's the notion of looking out for blood pressure in particular with regorafenib. It's 19, yeah. Okay, so I've covered that. Okay, just to come on and talk a bit about managing toxicities. This is not comprehensive, perhaps not completely instructive, but just to touch upon some kind of tips, really. So first of all, if anyone has any problems with any of these drugs, the first thing I always check is, how have you been taking it? Is what I think you've been taking the way it's been done? Because it's very easy to get confused because my head's in this all the time. It feels like second nature, but for a patient who's just starting on a drug the first time, it's not at all fair to expect that you would inherently know what's to be done. It's our job to explain it to you, and sometimes we don't do that very well. So we'll always check, have you been taking it the way that's intended? Sometimes the way that these drugs are taken in relation to food, the time of the day, can impact upon the side effects are felt, or at the very least there may be some ways of changing that to improve the tolerance. I would always check what other medication has been taken, because there is a whole list of other drugs which could potentially interact with the levels of something like imatinib, sunitinib in the body. And so, as a general rule, I always ask my patients, you know, if a doctor's ever trying to prescribe you a drug, if you're ever considering picking something up over the counter, please check with us first. Many medications are perfectly fine to take alongside, but there is a list of usual suspects which are perhaps of greater risk. And to check the brand of imatinib as well. So this is an area of interest, which I'm not going to go into great detail today. But as we've seen a switch from branded Gleevec to other brands of imatinib, which the main reason is there's a considerable cost saving for the NHS using these generic brands. In some cases, there do seem to be variation in the tolerance of Gleevec versus general brands, largely seen as people who were previously on Gleevec get switched over, perhaps less so than people who start on the branded ones. There may be an element of better the devil you know there. It does seem that for some people get on with some brands more than the others. The core drug, the imatinib, should be the same, but there are chemical differences within the pills which could account for that. I'm going to go through to talk about some management overviews, how I would approach some of the more common side effects of these drugs. It's not working, it's all right. So I'll go on to talk about fatigue, which, as we saw, is one of the more commonly encountered side effects. So first of all, I was always check. There are other causes of tiredness, which patients who have been treated for GIST are prone to get, particularly those who have had surgery on their stomach. They're prone to becoming anemic, maybe as a consequence of imatinib or other causes such as deficiencies in iron and B12, or possibly thyroid dysfunction. So your oncologist will always check for those. These are all easily intervened against. The time of the day that imatinib is taking, if you're taking it in the morning and you feel tired an hour after the dosing, perhaps taking it at night time might be helpful, where feeling tired for a few hours after the dose is likely to be less impactful. The role of physical activity has been looked into. There's a colleague of mine and Professor Stark's, Lucy Gossage, who gave a very good presentation at a conference recently around her interest in how maintaining exercise through cancer treatment can be a helpful thing and actually improve fatigue. That should be balanced against rest. If you're feeling very washed out, there's perhaps limits to if you go out and run a half marathon, that may not make you feel much better. But the general advice is to maintain a level of physical activity that taking to the couch, to your bed, resting too much can backfire. So moving on to nausea, as already touched upon, the relation to food can be important. The general advice is to take it during a meal. That does vary. For some people, it can be better to take it before, after food, sometimes away from food, sometimes breaking up the dose to take smaller doses with meals throughout the day can make to be helpful for that. There's a whole constellation of different anti-sickness medications which all work in slightly different ways, which your oncologist will be familiar with. There is an element of suck it and see with these, so your oncologist will start you on one and see if that helps. If it does, we'll persist with it. If it doesn't help, there are others to try. As already mentioned, the time in relation to sleep, particularly if one's getting problems with reflux and indigestion, taking it early in the day can be helpful, where you're going to be upright, whereas reflux can be exacerbated by lying down flat. And already mentioned, looking at changing the dosing schedule, potentially dose reduction for if nausea is particularly problematic, although it's rare that be required. Diarrhea often will respond to things like Imodium, the sort of thing you can pick up in the supermarket, and it's perfectly fine to use that along with these drugs. There is an advisable way to use these, so your oncologist will always check that you're using this correctly. I say oncologist, your care team, often specialist nurses who often will know more about this sort of thing than your oncologist. Making sure that you're taking on adequate fluids and diet. If one has lots of diarrhea, you're at risk of losing electrolytes, so making sure that they're kept up. So for some people, spicy food can exacerbate diarrhea, so sometimes avoiding spicier food is advisable. Radar keys is an indirect workaround. What these are keys that provide access to disabled toilets, which when you're out and about, so if one does have problematic or unpredictable diarrhea, I've known patients fear leaving the house because they need to know that there's a toilet nearby. If that is a problem, then these can be got from kind of online kind of disability living services as well. So if problematic diarrhea is an issue, this is getting a radar key is likely worthwhile. There's interest in the role of the bacteria that live in our guts that might modulate these sorts of effects. There's interest in the use of probiotics. There's no convincing data for that, but in some people I've known have started taking probiotic treatment and seen that to help. Likewise, other dietary issues, I've seen the case that people have cut out dairy and found that there's actually seemed to be an uncovered lactose intolerance. So there's different ways that diet might feed into these side effects. Rash, which is often the most common side effect that leads to people having to abandon these drugs, such as imatinib. It's always worth making sure that it's due to the drug rather than some other effect. Imatinib and other tyrosine kinase inhibitors sensitize to sunlight, and so be careful around that. It can predispose to sunburn. Many rashes are mild and will go away by themselves, sometimes requiring some fairly light touch treatment. More bothersome cases can require more heavy-duty interactions, sometimes referring to a specialist or sometimes changing the dose of these drugs. A particular sort of rash is the hand-foot syndrome, which can be seen with sunitinib and regorafenib. Making sure you've got footwear that is relaxed fitting but well fitting, making sure that you're getting the air to your feet, sometimes supportive insoles that spread the pressure across the feet all can be helpful. Moisturizing regularly is important. There are other creams that anecdotally at least, seem to help. And sometimes, again, demanding changing of the scheduling. And muscle cramps, which, for people who get it, can be quite problematic. Making sure you're well hydrated can improve, making sure that levels of different electrolytes, which can contribute to cramps, are optimized, are important. Quinine can be helpful. Quinine also found in tonic water, which may inform your choice of evening cocktail. And then I think finally, the high blood pressure, which is seen with sunitinib and regorafenib, it's really important that this not be overlooked in the management of these. And sadly, from time to time, we do see people have serious complications, heart attacks, strokes, which often go hand in hand with blood pressure that has been made dangerously high on these drugs. So it's something that your care team should be attending to. If you're able to record it at home, that's a useful tool. I do like it when patients come along with their own blood pressure diary rather than having to rely on whatever their blood pressure is in clinic that day, which often is a few notches higher just through merit of coming to see me. Not infrequently, starting blood pressure medication is required to keep being on these drugs safe. Blood pressure medication is rarely the cause of any particular problem. So just to bring things to a close, sorry, I think I've run a little bit over. Tyrosine kinase inhibitors play a central role in the management of GIST and work very well. And as I think Dan and Judith will come on to talk, there was a time not so long ago where in many cases there were no effective treatments. So these are highly useful drugs which have made a tremendous difference to the lives of probably approaching millions of patients by this time. There are different drugs. There are generic side effects, there are specific side effects that your care team will be familiar with. As people change from imatinib to sunitinib and onwards, there can be a change in side effects, and which requires closer monitoring. My expectation, what I tell to patients, is that we need to keep our eyes and ears open to side effects, but for every patient I start on these drugs, my goal is for them to be able to take it and for it to have either no or a very minimal negative impact upon their day-to-day life. And in a majority of patients, that is achievable. And there is a variety of strategies for managing side effects. Your oncology teams, your oncologists, specialist nurses, pharmacists are all experts in managing these. So it's just a slide to say where can you get further information. Again, the team looking after you, and then the UK charities, Just Cancer UK, Sarcoma UK, and then the equivalent US charity, the Life Raft, and peer support is a really helpful source of input. What's helped for other people who've been in your situation. And I continuously learn from my patients who told me, I spoke with a patient in the US who tried this, I've done it and it's worked, and I file that away for the next time I encounter those side effects. Okay. Thank you very much for listening.